The inside story on the issues that affect you and your community. This is Local 12 Newsmakers.
Was a heroin addict. I thought heroin addicts were people that lived on the street, people that were not loved, people that were from New York City or downtown Cincinnati. They just really didn't have families and no one cared about them.
Before I became addicted, I thought a heroin addict was a homeless person or a lowlife or some type of criminal degenerate.
Before Tabitha became addicted to heroin, I thought a heroin addict was someone else that lived in other neighborhoods.
Good morning and welcome to Local 12 Newsmakers. I'm Dan Hurley. The myths around heroin and who is at risk of becoming addicted prevent most of us from dealing with the reality. But Northern Kentuckians who have experienced an epidemic level of heroin use among middle-class suburban young people have decided to do something about it. One response has been the production of a simple, straightforward, and very powerful video by Chris Stegner of bluegrassphotography.net. Before we talk about the response in a larger sense, let's take a look at another section of this video about the reality that comes home and where people look for help.
Once I admitted to myself that Tabitha was addicted to heroin, I felt like my love was strong enough to fix her. I didn't think I needed help.
We really didn't know what to do for Taylor at that point other than to get on the phone and start calling.
I didn't have a clue what to do when we knew that Casey was addicted. I just reached out to anybody and everybody that I could talk to, and I talked to everybody.
When I found heroin in Tawny's purse, I turned it into the police, and I was shocked that they didn't ask me where it came from. They just took it.
When I knew I was addicted and I knew I couldn't stop, I knew there was options out there for me, but I was too scared to pursue them.
Our first thought to get Nicholas help was to take him to the hospital.
When I realized I was addicted, I thought that I could conquer the addiction on my own.
I had no idea what to do.
When I first found out that Brad was addicted, I didn't know what to do.
I was able to call his work because I know every work has a hotline. He worked at a hospital, and I called them and asked them if they had benefits for their employees without telling them his name.
When I went to see my physician and asked for help, I was told that they usually farm those people out, and I was wished good luck. I gave him the number, and he never called.
When I took Nicholas to the hospital for help, as we were leaving, the only thing that we were given was a handwritten list of detox centers that we could potentially call.
Unfortunately for James, the 30-day program was not enough, and he could not afford a longer-term program.
Tasha was court-ordered to go to numerous rehabilitation centers in which she walked away from.
While in the recovery center, Tabby was there for 3 months, and we realized that just wasn't long enough.
When I decided to get help, I was put on a waiting list for 4 months while I continued to use.
I called every place in the area, and they all told me that they were full and they had a 3 to 6 month waiting list.
Because resources were not available and there were no beds, Chris found no way out other than taking his own life by suicide.
What would have made a difference for Taylor would have been our understanding of heroin addiction. To realize that going away to a treatment facility, a rehabilitation center for 2 months, there's no quick fix for heroin addiction. That it requires a long-term recovery plan to maintain a life of sobriety.
What would have made a difference for me is being able to get help sooner.
It would have made a difference if my physician had treated Casey with the same care and concern and knowledge as my physician treated anybody else that had a chronic, progressive, potentially fatal disease.
At St. Elizabeth hospitals alone, the number of heroin overdose cases has almost doubled in the last year. The good news is that confronted with a growing problem, individuals and organizations in northern Kentucky have decided to take action. On Thursday night, hundreds of people showed up at the Northern Kentucky Convention Center to hear the results of the work of the Northern Kentucky Heroin Impact and Response Workforce. That plan calls for increased awareness, more physicians trained in treating addiction, and more treatment and recovery centers. To discuss that plan going forward, I am joined by three people this morning who have taken a leadership role in that effort. Steve Stevens is the president of the Northern Kentucky Chamber of Commerce. Dr. Jeremy Engel is a physician with St. Elizabeth's Hospital. And Ann Barnum is a senior program officer with Healthy Choices in Substance Abuse with Interact for Health, what used to be called the Health Foundation. Steve, welcome back. Jeremy and Ann, welcome to Newsmakers. Jeremy, let's start with you. Just how extensive, we get hints of this, the plan goes into a lot of detail, but just how extensive is this problem, and how recently has this become a trend?
So I'm just going to tell you my best understanding, obviously, as a family physician, the date I decided to get highly involved in this was about a year ago, over a year ago, and I had 18 patients scheduled. My patients tend to be older. 17 showed up, unsolicited. I wasn't even paying attention, just going through my day. I had 5 patients that either had a child or grandchild actively using heroin that day.
In one day?
In one day. And then that same evening, it was a tough day for me. It was a long day. I had set up for after hours. I worked at after hours. And in my after hours schedule, at the end of the evening, around 10, which we usually should be finishing up, a young woman in her 20s and her mother came in, and they were asking me, my daughter's overdosed 3 times. I can't get her into treatment, and I don't know what to do. What can I do? And so basically I was calling up the emergency room. I kind of remembered what to do, and basically I didn't have any options. I told her I would try, and I figured out a few medications to get her through a detox on my own. And then that same evening, as I said, it was a tough evening, I was on call, 3 o'clock in the morning, and at that point, the emergency room doctor called me with a routine admission, and DKA, which is diabetes, diabetes attack, basically. And he just kind of mentioned, and heroin, as if it was a color of the, a female, age, whatever. And basically, after I called him back, I said, what's going on? Because we both knew what was going on. We've been hearing about it for months. And we both said it was time to start looking into it. So at that point, he started, he talked to his office manager, and we started looking at this. This was a year ago. And guess what? It hasn't changed. It's just more of it, and people are now talking about it. But that was the beginning of my deep understanding that we had an issue.
And how long have you been practicing?
I've been practicing in Northern Kentucky for 13 years.
Okay, so it wasn't like you just moved here and all of a sudden.
No, this was, it had been present before.
Right.
I had people that I knew that were impacted, but it was kind of like on a lower level.
Right.
I didn't get it then.
And obviously, there's a sense that any of us, whether we've had any direct connection to this or not, can sense that for the individual, certainly, and for the family, this is pretty devastating.
Absolutely.
You're holding a chart, which we're going to put up on the screen. It's hard to read. This goes way beyond, though. The implications go way beyond just the individual and the family.
Oh, absolutely. We saw in Northern Kentucky 90 deaths due to unintentional overdoses to any kind of opiate in the past year. We saw 61 that were directly related to heroin. 61 deaths.
I just have to stop. How, again, as the historian in me, I like timelines.
Yes.
How would that have compared with 5 years ago?
5 years ago, we might have seen 1 or 2.
Okay, so we're talking about an explosion.
We have seen an explosion in this.
Okay.
And we've seen it in all kinds of areas. We've seen it in criminal justice. There's been an explosion in the criminal justice arrests due to heroin. So heroin-related drug trafficking, but also people doing burglaries and robberies related to getting money to support their habit.
Okay. So just give us a couple of cents in statistics, and we can put this full screen up, please. And what's the cost? What are some of the costs involved?
Well, for every death that we have, we also have a new case of hepatitis C. So there have been about 61 new cases of hepatitis C in this same time frame, and that costs us $64,500 for a lifetime of care. For every death, there's a baby born who has neonatal abstinence syndrome.
Jeez.
And that costs us, on average, $14,000 to $15,000 for that first hospital stay. But the cost for that child may be lifelong. We don't know a lot. We know that if we provide good care at the beginning of life for these children, that they can grow up to be normal children. But if they're going to a home where mom or dad or both are using heroin, oftentimes there's neglect, oftentimes there are other things, so that the child doesn't get the best care.
And then the courts get involved, and then there's other public
absolutely
costs.
You know, the good news is that there are, for every death that we have, there are 33 people who are admitted to a detox unit.
Okay, we're going to get to that in a minute.
I would just state that in my experience, it's usually a family member who's now taking care of that child.
Yes.
And so you have a balance between a family member who gets kinship care, financial support, which is much less than foster care,
right,
who usually is a senior living on a fixed income, or maybe there's a married couple where they're older and one's working and one's not. And so you have a financial situation where that same grandparent couple or somebody else, may not be grandparents, are doing two things. They're trying to save themselves, which they don't, because they can't take care of themselves. They usually can't. Take care of a grandchild or one or two, and at the same time try to balance the fact that they have a loved one who's actively using, who is disrupting their own lives, and who's either they're trying to balance it. So you're balancing three dysfunctional systems in one household without any support. And guess what? That doesn't work very well.
Yeah. Steve, you're the president of the Chamber of Commerce. You've taken a real leadership role in this effort. Why? Why is the Chamber interested in this?
Well, Dan, this is an unconventional issue for the Chamber of Commerce, as you well know. This is typically something that we have always given over to the social services or human services entities. And quite frankly, it is so much bigger than that, because this is a community issue that, you know, it transcends everybody. And this hits all walks of life. This is a major cost to the community. If you want to be a community that is attractive for people to live, for people to work, for companies to come here, then you have to address this problem. You have to fix this problem seriously. It goes into the workforce. You know, the Chamber is very supportive of workforce development. And what does that mean? We want talent development. We are losing some of our best talent because some of these tragic cases, some of the folks that we saw and heard about at this forum the other night and we have learned about, had tremendous potential for our community. Our companies need them. Our churches need them. Our educational institutions need them, and social service agencies and organizations. So it's a major cost that people can't even imagine. So, you know, yes, business cares for a lot of reasons. Quality of life is critical to business growth and prosperity as much as it is to bringing a workforce in and supporting that workforce. But you think of lost productivity to those people that are in the existing workforce who unfortunately may end up with an addiction, or they have to deal with a family member and it's on their minds day in and day out when they come into the office or the workplace, and it's just it's a burden. So this is a cancer. It's a plague. It's growing exponentially, and it's way overdue time for us to get into it.
And Interact for Health is a regional effort. It's not just a Northern Kentucky effort.
No.
Is there any reason to believe that what's happening in northern Kentucky is any different than what's happening on the north side of the river?
Absolutely not. Absolutely not. It is happening over here as well. We've got a group that has formed over here that's starting to do this work. We need more people to join us in this effort on the northern side of the river. Over here, our statistics are that we have a death due to heroin or other opiates every other day. That's
wow.
A person every other day is dying in Hamilton County. We had 204 in 2012.
Jeez.
And most of those deaths, where do you think they might be happening? Where do you think they happen?
Well, I think from what we heard, people presume they're happening in the inner city with the poorest people, but my suspicion is that you're going to tell me that's not true.
That's not true. That is not true.
So where is it happening?
Most of those deaths occur at Bethesda North Hospital.
Well,
this is a suburban problem. The suburban users, urban sellers.
Okay. Welcome back. I'm joined this morning by three people involved in an initiative entitled Drug-Free Northern Kentucky, an effort to address the serious heroin epidemic in Northern Kentucky. Ann Barnum is a senior program officer with Interact for Health. Dr. Jeremy Engel, to her left, is a physician with St. Elizabeth Hospitals, and Steve Stevens is the president of the Northern Kentucky Chamber of Commerce. Dr. Engel, what would you tell a person who's out there watching right now, who says to themselves, I think I know someone who's involved in this. I think I have a child who I have a hard feeling that maybe something's going on here. What would you tell them to do?
Well, I mean, you know, people ask me why I'm motivated by this process, and I tell you the truth, that the answer to that question is I'm sickened by I can't give you a good answer. I do know some people that may or may not be able to provide treatment. The problem is that I don't know if that individual, if I was to try to help them get treatment, if they could get in, if they can afford it, if they have access. The whole issue, from my perspective, is my mission is to have this so that I can give them the right answer. Just like if they came to me and they think I'm a new diabetic, or I have hip pain, or I might have a problem with my shoulder. I can get an individual with an 88-year-old individual. I've had this happen within the last couple of months. Beautiful patient, 88 years old, who has an arrhythmia. I can get her seen by myself, a specialist, a subspecialist, and a pacemaker in 3 days. But if I have a 23-year-old who's an addict, I can't get them treatment that's adequate, that I know will get them over time, because it's a chronic illness. Yeah. That is the reason why we're all here. That has got to change.
Yeah. Steve, there's the need for, and the plan goes into all sorts of things that are needed. Better physician training, awareness, but there's also things like there's got to be more places, there's got to be more treatment beds, there's got to be ability to have people treated for longer periods of time. How does this plan begin to address those sorts of hard issues that are involved?
Well, it really lays out a tremendous framework for us. You know, we talked about really a six-prong kind of an attack on this, and you know, two of the big ones are, you know, reduce the supply, reduce the demand, and advocacy. Infrastructure is critical on the treatment side, because the whole bottom line of this is saving lives. And once recovery has taken place, no relapse, but getting back into a productive state, you know, and so that takes money, that takes facilities that will treat those individuals.
And I take it from reading and from what Jeremy just said, it's going to take new facilities and expanded facilities.
Yeah, and the statistics that we saw last night, basically, you know, there was somewhere on the order of, this is a not accurate number, but 1,000 or so folks, or 1,000 or so slots available for us to do a variety of different treatment types. But, you know, we had about 6,000 folks come through the system. It may have been 1 day, may have been 3 days, may have been multiple days in a lot of different treatments, but the fact is there's a huge imbalance. You know, we cannot take care of the folks that are, you know, experiencing trouble with this issue.
And Steve, we've got 26,000 who need treatment right now.
26,000 where?
In Northern Kentucky.
In Northern Kentucky.
26,000 who need treatment for addiction of any sort. That would be to heroin, to other problems. And you really can't, you know, you can save beds for people who have a heroin problem, but you've got people who walk in with other addictions as well, and you need to treat them as well, or their addiction is going to get worse.
I'm going to start this with you, but anybody can answer. Does the Affordable Care Act change the dynamic here at all?
Yes.
It does?
Yes,
How?
it does. Well, there are two ways that it does. One is that in its purest form, the Affordable Care Act provided parity, which is, it provided that addictions and mental health would be treated in the same way that other diseases would be treated. As Charlotte Wethington said on that little piece that you showed earlier about treating this as the chronic, progressive, potentially fatal disease it is. If you had cancer, you would, or this person that you were talking about, Jeremy, you can get people into treatment, you can do that, but with addiction, that's not the case. And we need to be able to treat people appropriately, and the Affordable Care Act allows us to do that. It says that you're supposed to do that. That insurance companies are supposed to cover that. The other part of the Affordable Care Act that helps is that in Kentucky, we have Medicaid expansion, which allows us to bring more people into those roles who cannot afford insurance and are not covered. And along with the Medicaid expansion in Kentucky, the Medicaid office is trying to expand the types of substance abuse services that they offer.
I'm very aware of time. Dr. Engel, is heroin addiction, once a person is addicted, is it possible to be treated? Is there success in this area?
Yes, I mean, I've met people in treatment, and I'm a family physician who's trying to understand what the right answers are. My suspicion is that they need to be on a medication that would stabilize them so that they're not interested in heroin. Something that's called medicine-assisted treatment. The traditional ones have been methadone, and there's one called Suboxone, and there's one called Vivitrol. They have different uses based upon the individual. In my traditional medical practice, I would be able to prescribe all medications for any illness. The way we're set up, though, is you have to go to different locations for different medications based upon what licensure we have. Right now, we don't have enough Suboxone treaters. We have a new methadone clinic that's doing a fabulous job stabilizing patients very rapidly, and guess what? They do very well. The likelihood of relapse in a person not on medicine-assisted treatment, and when I say medicine-assisted treatment, I include therapy, include support. It's the whole package. But without medicine-assisted treatment, the statistics show 85% relapse rate. And unfortunately, you know, with cigarettes or alcohol, that's problematic. With heroin, that could be overdose, death, IV drugs, or whatever. With medication-assisted treatment, it improves by at least 50%, if not greater, depending if you have the whole environment. And I've met these people. They do well.
Okay, unfortunately, we're out of time this morning. I want to thank all of you for the work that you're doing. We're going to have you back. We're going to track this. But for people who want to find out more about this initiative in Northern Kentucky, and remember, the information can apply to people no matter where they are, real practical information, go to the website, drug-free NKY, all run together, .org. Thank you for making Newsmakers a part of your Sunday morning. We leave you with the conclusion of the Dark Truths video by Chris Stegner of Bluegrass Photography. Let the people speak who have been affected.
Don't ever believe that this cannot happen to you or a member of your family, because it can.
You need to know that heroin addiction takes lives and destroys families.
If you think something's wrong, it probably is. Trust your gut. Don't deny that something is happening right under your nose. Trust your instincts. Act now.
People need to know that heroin will take over your life.
You need to realize that no one wants to become an addict.
You need to know that sending people to prison is not a solution for drug addiction.
I think you should know you can try heroin one time and be hooked for the rest of your life.
I would like people to know that casual marijuana use can lead to heroin addiction.
You need to know Nicholas did not want to be an addict.
People need to know that heroin does not discriminate and anyone's child can become addicted.
You need to know that our children need to be educated about heroin or this epidemic will not stop.
You need to know you know a heroin addict. You just don't know it yet.
You need to know heroin will kill your child.